Good evening, everyone. My name is Mary Smith, and I'm a physical therapist with Onondaga Physical Therapy, and welcome to our first webinar. We are so excited to have you here tonight, and we have Dr. Emil Azer from Upstate Orthopedics, who is going to join our team to talk about when a good knee goes bad. Physical therapists on deck here today also are Damond Archung and Garry Campbell. We want to have a lot of fun with you guys tonight, and I think we've got a great little trio here to do that. Our goal is to educate you on the knee and treatment options when that nagging knee pain just won't go away or you feel like you've exhausted every option. Our agenda tonight is going to be, we're going to do a little bit of an intro and housekeeping. Then we're going to get Garry going about talking about preoperative physical therapy, because yes, you do and should do physical therapy before your knee replacement. Next up, we'll have Dr. Azer discussing excuse me, the disease process with osteoarthritis and some non-operative interventions. Then we will have Damond discussing post-operative PT and all the things we'll do to work with you to get you to your goals to return to living, working, and playing better. Just some housekeeping things. We're going to keep everybody on mute tonight so that we can minimize any background noises and distractions. There is the chat panel at the bottom. It might say Q&A. I want you to leave all your questions there. We're going to leave about 30 minutes at the end of the webinar for answering questions. If for any reason we don't get to your question, we will have them recorded, and we're going to work to answer your questions after the fact as well. Once we sign off tonight, we have about 2 hours here, so we're going to be good till just about 7. There will be, when you sign off, a survey for you to take. And we really appreciate in advance the feedback that you have for us on our performance tonight, the information, and that will help us continue to improve for our next webinars going forward. You will also receive an email tomorrow with a recording of this webinar. So if there's anything that you missed, you'll be able to go back and view it again and again. So without further ado, we're going to pass it over to Garry to start up when a good knee goes bad.
Hello all, good evening everyone. I hope I'm coming through loud and clear. This is my first webinar where I get to be a presenter, so I hope we can do some good things tonight. Again, my name is Garry Campbell. I've been involved with physical therapy for over 20 years. I graduated from Western Carolina University and then moved home to where my family's from in Syracuse, and I have been with Onondaga Physical Therapy for 17 years. So I've seen a lot of knees over the course of my years, and I'm here to tell you a little bit about it. So I have a knee demo here. It consists of 4 bones, basically. The fibula and the tibia are the 2 bones of the lower half of the knee, and the femur is the bone of the top half of the knee, and the patella, which basically sits right in the front and glides north to south. It's considered a hinge joint, and most of the joint happens forward and backwards, flexion and extension. On the base of the femoral condyles are what's called articular cartilage. It's a very smooth bone, and that over the course of years, you get a little wear and tear. That smooth cartilage starts to break down. It becomes kind of pitted or potted, and then those areas become inflamed. And that's when you get to the degenerative changes of arthritis, where you get stiffness, swelling, decreased range of motion. And if I could just pause for a second, I can't see the slides. So
let me grab you those slides. I just wanted to screen share.
So hopefully now everyone can see the slides of what we're talking about. And so there's our panelists. We can go to the second slide. There you go. So the quick overview is when you start to experience these degenerative changes, you kind of get caught in this vicious circle, if you will. The knee starts to hurt. You start to have decreased tolerance to daily activities. Increased pain, increased joint stiffness leads to decreased activity. So you just don't do as much, and sooner or later you're not as active as you once were. So some of the benefits to coming to PT throughout the course of the disease process is to help to reduce that pain, improve knee function. Prehab right before is to strengthen the knee, hopefully to get better results, less time and admission to inpatient rehab and a hospital stay, and get you back home and doing what you want to do. Over the course of the disease process, you may experience knee pain. You come to physical therapy for various reasons. Here in the Liverpool Clinic, we have aquatic therapy, which is very useful. Due to buoyancy in the water, you don't weigh as much, so the compressive forces through the lower extremity joints, such as your ankles, knees, and hips, is much less. When you're in water up to your chest, about 80% of your body weight is floating. So if you weigh 200 pounds, you have about maybe 40 pounds of pressure going through your knee joints. So that can be very helpful, especially some doctors might want you to get in a little better shape and lose some extra pounds before they do a joint replacement surgery. So we have that here, but mostly we're going to stick to talking about immediately preoperative. So you may go to see a doctor, you get to that point where the x-rays have realized that the degeneration is so far along that it's bone on bone, and you have your nice friendly orthopedic surgeon willing to perform a total joint replacement. A lot of times they'll send you to prehab. I think you can go to the next slide. And it's about a 1 to 2 visit plan of care, basically, to come, and as a physical therapist job, we want to teach you exercises to learn to do at home, even in the previous 3 to 4 weeks before the surgery, just to help strengthen up those muscles a little bit more, get the knee joint moving a little bit, increase that range of motion. A lot of times, not only will you come in pain, but because of years of non-use, you might lack a little bit of range of motion, most notably into that terminal knee extension or getting your knee straight, which will cause a compromised gait pattern. And so by helping increase some of those muscle strength to kind of get that joint moving a little better, it's designed hopefully to get you stronger right before the surgery. And a lot of the exercises will be the same even post-operatively to get you strong after your surgery. So on this slide, you'll see a login URL, onondaga.pt.medbridgego.com. MedBridge Go is an exercise program that I use here to hand out home exercise programs. If you enter that website into your web page browser, hit enter, it'll ask for your access code. Anybody can type in that access code and view the exercises that I'm going to go over tonight. When you go to that website and you pull up the exercises, there'll be a little play button that if you push the play button, someone will demonstrate and describe for you how to do these exercises. These exercises are very basic. My hope is that if anyone tries them at home, you're able to do them without any significant increase in pain. But also, I'm not attempting to diagnose anyone in their knee pain tonight. So if you do any of these exercises and you're experiencing pain, please reach out and give a doctor or physical therapist a call so we can give you the exact exercises you need. All right, I'm going to switch computers now and bring in my co-presenter Damond, and I'm going to go over the pictures on the next slide are some of the exercises that we can do.
We're just going to get set up for the demonstration part next.
All right, if we can bring it right over closer here. So keep your left leg off the table. Yep, and the right leg. There you go. Perfect. So the first one you'll see on this page in the upper left, the gentleman in the slide is long sitting. I've got Damon's left knee off the table here a little bit, just so for the sake of being in the picture. But what we want to do is this first one's very important. Like I said before, the knee joint is a hinge joint. So this quad set does 3 things. It works on the co-contraction of the quad set. So Damon, if you'd give me a nice quad set, you're going to squeeze that quad like you're going to push your knee right into my hand. Perfect. What we're looking for is a nice contraction through the quad. This VMO sometimes, if it gets weak, will cause, instead of the patella to track north-south, it'll cause it to wiggle east-west, which can also cause some pain due to arthritis. It also will force that knee right into a nice closed pack position. So if you have any joint effusion, which is swelling in the joint associated with arthritis, it'll help to kind of push some of that swelling out of there. So again, Damon, one more time. Good. A lot of times patients can't get their knee fully straight. So where my hand is a good biofeedback to get them to push down into my hand. You can also use a roll of a small towel if you can't get your knee straight. So that first exercise is called the quad set. Second one we're going to do is just a heel slide. Once we get that joint kind of compressed and some of the swelling out of there, we want to just do some gentle movement, continuing to use the quads and the hamstrings on the front and back of the leg, and then just get that knee joint moving. So it's simply just lift your knee up towards the ceiling, slide your heel towards your buttocks, and then straighten it back out. There's another slide where it shows it with a strap. So if you lack any kind of strength or pain with range of motion, it may be easier to use your hands. Can you grab me a knee and stretch out strap? So again, we're just knee up towards the ceiling, bending back as far as you can. With an arthritic knee, you want to go to the pain, not necessarily through it, because eventually we want to keep pushing that edge of the range of motion. So as we straighten back out, we have these neat little stretch out straps in our clinic. We can loop it around, just like I said. Now with Damon, he can help if he needs a little bit of help to bend the knee up to get a little bit more range of motion, because sometimes your muscles aren't strong enough to get it bent back as far as you need to. So just that little bit of extra help with a stretch out strap. Dog leash at home if you have it, and then we'll straighten it back out. Good. And the last one I put on there is a straight leg raise. And a lot of times when you start to get that arthritic knee, your knee doesn't bend and flex as well as it should. So you start what's called circumducting at the hip. Your leg kind of swings out instead of swinging straight forward and landing on your heel. So we want to make sure we have good hip flexion strength to help with your gait pattern, both before and after the surgery. So if you could just long sit just a little bit. So that straight leg raise, again, what I want to do is I cue in a good quad set, really kind of keeping that knee nice and straight, and then lift it up towards the ceiling, keeping your toe pointed right towards the ceiling, and then back down. Sometimes a compensatory mechanism is to toe out and lift up, which you use the muscles a little bit more on the inside of your leg, and that's what we don't want to do. We want to keep that toe right towards the ceiling, making sure we focus on the hip flexor. Again, leg solid, nice and straight, toe towards the ceiling, and back down. So those are my 5 quick therapeutic exercises for you to start preoperatively.
Do you want to move back to the slides, Gary?
Yeah, if we go back to the slides, I think the next slide is just about some assistive devices. Preoperatively, as your knee degeneration starts building, you may need to unload some of the weight off of your knee. So starting with a straight cane, moving up to maybe even a short base quad cane or a walker. We'll have another slide too as well. Oh, that one's good right there.
Yeah, okay.
And we'll have another slide too about durable medical equipment that they'll set up in the hospital. But really the preoperative goals are to increase the knee joint range of motion, reduce knee stiffness. We want to get those passive accessory joint motions moving very well, and to make sure that the patella is tracking, like I said, north-south on that hinge joint and not moving east-west at all, because that'll offer some pain as well. All right. Checking in with our chat room. Do we have any questions popping up there?
Let's take a look.
So anyways, preoperative surgery, you'll kind of want to make sure that if you're living alone, you might want to have a setup as you come out of the hospital, maybe an inpatient. Any ones that you want to, the chat might be over on the side. Anyways, we can go back to the slides.
Okay, all right. All right, so just switching over to a screen share again, guys.
There we go. So surgery prep, you want to make sure that home environment modification is set for you. As you come out of the hospital, they'll make sure that you have everything you need as far as portable commodes, raised commode seats in the bathroom if you need an elevated toilet seat, tub bench, bath mats, grab bars, all those kind of things. And I think that might be it.
All right, let's
We'll go to the next slide. Yep, and there's the assistive devices that I talked about, whether it's a standard cane, a quad cane, or the walker. And then now we're on to post-op.
actually, we are going to switch gears now, everybody, and we're going to have Dr. Azer discuss the pathology of the knee and some non-operative management. So go ahead and take it away, Dr. Azer. Okay, just going to take a 1-minute technical switch over. Sorry, everybody. Take a peek here at the chat. All right. So I believe there was some comments in the beginning that my volume might have been a little bit low in the beginning. So what I just wanted to have everybody here at the beginning was that we're working on to do a Q&A in the last 30 minutes or so. So if you have a question, leave it in the chat bar and we will get to your question toward the end. If we are unable to in the time we have tonight, we will certainly get back to you later on with an answer.
We're good to go. Okay. Where's volume? I think you should be good. Okay. Hello. Okay. Let me do that over. I'd like to thank everybody from Onondaga Physical Therapy for inviting me, Mary, Gary, and Damon. Just want to talk today about knee pain, arthritis, and how it relates to physical therapy, all the way from the diagnosis, what to do before the diagnosis, what to do before surgical management, and some non-surgical issues and treatments. So a little bit about myself. I've been here about 11 years. I practice orthopedic trauma and joint reconstruction, which is basically knee and hip replacements. I am from the New York City and Long Island area, and I've been here for about 11 years taking care of knee arthritis, hip arthritis, and basically anything that breaks. So let's get started. So my little spiel is, at one point in time, you might have been able to do this, maybe look like that, and you have a lot of expectations from your joints. And what happens is is it doesn't always last, and that good joint becomes a bad joint. And the question is, why does that happen? Knee pain is one of the most common reasons for an orthopedic visit, and it can be anything. The vast majority is self-limited and gets better on its own. Sometimes it doesn't, and you can have things such as meniscus tears, a ligament tear from a trauma, what's called patellofemoral syndrome, cartilage defects, which could be related to arthritis, fracture, infection, osteonecrosis, which is I'm going to touch upon, and arthritis. So let's talk about these. We're not going to belabor the acute traumatic injuries. We're going to really talk about the degenerative. Like Damond gave us, Garry had given us a very good demonstration of what the knee looks like. We're going to get into some more pictures too. Other causes of knee pain are the hip or the spine. That's something else that we need to figure out as the root cause. So what exactly is osteoarthritis? The symptoms are usually pretty typical. Pain with activities. Even things such as a walk in the park, as these fine folks are doing, turns out to be a chore, and it's painful. And maybe at one point you're able to walk miles, then not so much, and becomes a chore to go from point A to point B, even if it's only a few feet. Stairs and pain with activities are hallmarks. So rising from a seat is also something that is something that's taken for granted. This could be one of the most excruciating events, just getting up from a seat. And a limited range of motion, stiffness, and walking with a limp. These are things that people present with osteoarthritis. And there are many kinds of arthritis, but we'll stick to osteoarthritis right now. So the doctor says, I have arthritis. What do I do? That's the big question. So I am an orthopedic surgeon. I do knee replacement surgery all the time, but truth be told, not every knee that has arthritis needs any type of surgery. It's common, but again, the vast majority can be treated, especially in early stages, with conservative treatment. And one of those is physical therapy. So we're conservative in that respect. We start slow. We on the ladder of complexity, we start with the most basic things. So let's start. Treatment options. Two of the big ones are weight loss and activity modification. So the old joke, you go to the doctor and you say, hey doc, when I do this hurts my knee or my hip or whatever. The doctor will tell you, stop doing it, and here is your bill. And there's actually a lot of wisdom to that old sitcom joke. And really, activity modification is huge. If something does bring on the pain, it should be avoided if possible. Another thing is weight loss, sensitive topic. Nobody likes to talk about weight, but it is something that's very common in all walks of life. And when you have a joint that is subject to even that little amount of weight, losing it actually may help. Walking aids, and this goes hand in hand with physical therapy, because using something such as a cane can actually help offload the joint in question, and that is a form of activity modification, such that if something is bothering the knee, and you take some weight off, or give us a sort of another avenue for support, such as a cane or even a crutch, that may help. Physical therapy. This is one of the most misunderstood things. People think physical therapy, at least even when I was younger, that physical therapy was, I'm a member at the gym, I know what I'm doing. It is so much different than exercise. There's a form of exercise, but there's many modalities. Just like the rest of the panelists can attest to, there are things that that's done in physical therapy that's not known to the common person or even somebody who is very active and even the athletes. Other things is anti-inflammatory medications. That's more along conservative treatment that I would prescribe, and things such as supplements such as glucosamine and chondroitin sulfate. Now, the literature, the data, the scientific data isn't very clear on whether this really does play a big role in mitigating symptoms or preventing progression, but the side effect profile is relatively low. And if it's something you thought about, it may not be a bad idea. There are some anecdotal studies that show it does work, especially in early arthritis. Other things that I'm going to just touch upon is more along the lines of the rheumatic arthritis and not really the osteoarthritis that's from wear and tear. And these are, they call them symptom-modifying antirheumatics or disease-modifying antirheumatics, the SMARDs and DMARDs. That's something that your rheumatologist or your PCP would be able to explain more if you are a candidate and if you have one of these diseases. And other rheumatologic medications such as prednisones and the steroids. So what does weight loss do? Well, what it does is it decreases the force on the knee joint. It may improve mobility. If you think about it, if you are heavier, it's easier to get around if you lose the weight. And it does reduce pain because of that force. The physical therapy is something that, as I said before, it may be misunderstood by those that really don't see a role. As Garry pointed out, that in some of these exercises and with the anatomy of the knee, you have a joint that hurts. When a joint hurts, you are more reluctant not to use it, or you're more reluctant to use it rather, such that sometimes you need to be guided and forced to move it. And that does sound painful, but all of these modalities such as ice, heat, and ultrasound, electrical stimulation, and other manual techniques, the manual therapy, even massage, these are things that therapy can support you and sort of get beyond that hurdle. It's not something that we can just say, okay, do these exercises. You can in some cases, but with the guidance of a therapist and with these modalities that may decrease the pain that would make you reluctant to move your joint, maybe that obstacle can be obviated. So things such as heat, ice, and ultrasound are fantastic modalities. Electrical stimulation is something also that can be used. Taping is something you see oftentimes with athletes. And what it does is it improves the motion in cases where it's just pain. There are some cases where this motion is not secondary to just pain, but is secondary to the fact that there's actually a mechanical block. That is something that may not improve much, but it is worth a shot as long as it's not provoking pain. Another thing is improving your strength. Just like we saw earlier, if you force or if you strengthen the quadricep, you're actually helping the knee track better, and you're able to overcome the effusion, the bogginess, and the swelling of the knee, which is usually just fluid filled, and you're making the kneecap track better. Oftentimes, the kneecap pain is quite painful when it's wobbly. And one of the most important things that I want to discuss is speeding recovery time. I always tell my patients that I'd rather you do a little more therapy before surgery than doing more therapy after surgery in the hospital. So if you're at home or as an outpatient doing your prehab, as we call it, I'd rather you do that a little bit if it can foreshorten your hospital stay. And I think this is huge in preparation, knowing what to expect. And I think it's huge in preparation of really getting you in a mindset that you are going to hit the ground running after your joint. The psychological advantage of being through it and knowing what to expect is tremendous. So let me go over the knee anatomy again. Femur, tibia, and patella. The patella is the kneecap, the femur is the thigh bone, and the tibia is the shin bone. The fibula participates in the joint, but it's not something that we're going to belabor. This is your normal anatomy. Articular cartilage is the term that we use for the nice shiny surface. And this is what is subject to the pitting and the potting that we just saw before. These are called collateral ligaments and insider cruciate ligaments. There are some designs of knee replacements that substitute the ligaments in the middle, even the ones on the side, but not a conventional knee replacement. So these are the rings called the menisci. Somebody can have a tear of the meniscus and have significant pain from the tear and instability. And synovium, this is a sort of a layer inside the knee that nourishes it with what's called synovial fluid. And that's what you, when somebody says they have water in the knee, it's synovial fluid, and that's produced by the synovium. So we got to figure out why you have the knee pain before we start formulating a treatment plan. So there's 3 other sources of knee pain. You have nerves that are feeding the sensation of the entire limb. So this could be a compressed nerve in your back causing knee pain. This could be a hip problem, and it's called referred pain from the hip, where you would actually experience knee pain, but really is not intrinsic to the hip, but it's because the plexus of nerves that give you sensation to the hip and the knee are intertwined, and you might get that. Same thing with the ankle pain. You could have an ankle issue causing this. Acute is one thing that I see all the time, where somebody is injured, and that's trauma or even an infection. And the chronic ones are injuries that have happened maybe years ago, and that little injury may have caused instability. And if you caused instability, you are oftentimes causing a painful situation, and it can progress all the way to frank osteoarthritis and bone-on-bone disease. And infection could also be chronic. As we said, this could be trauma, fractures, or sprains and strains, or tears of the tissue. All of this is soft tissue here. There's the medial meniscus, which is the inside, lateral meniscus, which is outside. This is the PCL, which is called the posterior cruciate ligament, and this is the ACL, which is the anterior cruciate ligament. The kneecap is in the front. So it could be any of these that are subject to an injury. Now, what we're concentrating on is knee osteoarthritis. And what happens is that nice shiny cartilage that you saw before then becomes eroded, and it becomes pitted. And so it's, if you can imagine it in your mind's eye as a ball bearing or a marble, and then it becomes sort of like a pebble, and it's rough. That's where the pain comes from, where it's inflamed and everything that surrounds it gets inflamed as well. So these are a few things that we're going to talk about. This is an artist's schematic, but this is what it looks like. This is what it looks like on an x-ray. This is not normal. You can't see this space. This space here is represented by cartilage, and this is bone-on-bone disease. This is a big bone spur, so you also see little cysts in the bone. Take my word for it, it's hard to see on these x-rays, but you have cysts, bone-on-bone, which is cartilage loss, and bone spurs. So when this happens, we talked about all of these things: weight loss, activity modification, physical therapy, walking aids, anti-inflammatories, icing, bracing. Invasive could be things such as simple as a simple steroid injection, cortisone injection, if you will. Viscosupplementation, which I'm going to get into later. Stem cells and PRP, which is sort of experimental at this time and is not been proven. You have arthroscopic surgery, something called subchondroplasty, which I will get to in a minute, and total and partial knee replacement. What are the medications that we use? NSAIDs. Those are your Advils, Aleve, Motrins. COX-2 inhibitors are your Mobix and your Celebrex. And all of these can help the symptoms and as well as really calm down that inflammation. If you can break the cycle of inflammation, perhaps you can get to this goal of allowing the patient to continue in physical therapy. And you can reverse that vicious cycle: inflammation and pain, lack of motion, stiffness. Then you have increased stiffness, and increased stiffness leads to more inflammation, and so on and so forth. So if you break that cycle, more or less, you are able to combat this, but we're using all these modalities, including therapy. So things such as topical anti-inflammatories and lidocaine derivatives, they work as well. Again, there's no set rule as to, if you have really bad osteoarthritis, then we should use these medications. If you have moderate, you can use this. Really, it's sometimes a combination. Sometimes it's one that really does the trick. And really, our goal is to reduce pain, to try to improve your motion, and try to get the muscles around your knees stronger. And as Nancy Reagan used to say, just say no. Narcotics are not in my list. This is not something that's the appropriate medication for osteoarthritis. Viscosupplementation, they call them the gel injections or a lubricant, and these are FDA approved only for the knee. And when it's severe osteoarthritis, it's really not worth a shot, no pun intended, just because they're expensive, and if they don't have any real positive results when it's completely bone on bone. The fact of the matter is, every time you put a needle in someone's knee, you are risking infection. So if it's not going to work, I'm not going to try it. You're better off using a steroid in these cases. And there's many brands: Suparts, Synvisc, Euflexa. These are 3 brands. I'm not a consultant for any of these, so there's not one product that's better than the other. Stem cells and platelet injections are something that is used. There is a high cost to it because they're not covered by most insurance plans, and the potential to heal damaged cartilage is the theory behind this. And so there are some studies that show that greater than 50% relief at the same time points at these procedures in comparison to steroid injections. So it's not a consistent results. And again, these are costly and it's out of pocket. So it's until we get more literature and it's proven to actually have this positive effect of healing damaged cartilage, it's not a proven fact. PRP is platelet-rich plasma, where they would take some of your blood, spin it, and the platelet-rich plasma is re-injected into your knee. And this is also one of these signaling proteins and growth factors for healing the cartilage. Also, something that is not really proven in any big clinical trials. Subchondroplasty is something that I do from time to time, and what this is basically, if you see this big white, sort of a white, it's like a sunburst appearance, this is edema. This is fluid in an MRI of a knee. This is the femur, this is the meniscus, this is the tibia. Now, this represents a microfracture. Now, where would you get a fracture from? Well, oftentimes with arthritis, the cartilage is so poor that you get fissuring and little microfractures in the bone. Having said that, cartilage doesn't have nerves, so why does it hurt? Because the bone hurts. So one thing that can be attempted in some cases where there's MRI evidence of this, where you see this fluid, is you inject a type of cement in there that's absorbable, meaning the body will absorb it and it will go away. It's made of calcium, and what it does is it provides support to that fracture such that it allows it to heal, and it's for pain relief. It does not restore cartilage, however. Arthritis is progressive. So when all else fails, what do? We want something that resurfaces the diseased cartilage, realigns the axis, which is the center of the hip, the center of the knee, to the center of the ankle, should roughly be a straight line. When it's skewed one way or another, you load one side of the knee joint, and that exacerbates the deformity and exacerbates the pain. So those are the three goals. How do we do that? Total knee replacement. So this is the knee I showed you before. This is not a healthy knee. One thing you don't really see quite clear from this picture on your left is it's not a full picture or x-ray of a knee. So you don't know where your hip is and where your ankle is. But take my word for it. This is a bow-legged knee where all the cartilage loss, or the majority, is inside, causing bow-leggedness. That's one of the problems of the most common type of arthritis. Having said that, we want to realign that within reason. Sometimes the deformity is too far gone, and those are exceptions, but we want to align it by making some bone cuts and releasing some of the soft tissue so it's balanced back to where it should be. So the series of bone cuts generally is from the kneecap. You resurface that, and there's usually a polyethylene button, which is the new surface. Here, you make a series of cuts that's roughly octagonal. It's in the front, the back, the distally, which is the bottom, and chamfers, and usually a straight cut of the tibia. Get rid of all that diseased cartilage. So big question I always get asked is, if after a knee replacement, can I get arthritis again? Well, there's no cartilage, so you can't have arthritis again because all the cartilage is replaced. And it kind of looks like this. So this is a schematic, and it's a cartoon where this is metal, and you're looking at the picture as if you're looking at someone's knee. So this is the fibula, that's the outside. This is the tibia, this is the femur. The kneecap has been removed for simplicity's sake. This is metal, and this is polyethylene, which is a type of plastic. And so this is your new surface, this metal on this polyethylene, and it looks like this on x-ray. As you can see, there is a space here because we've reconstituted that space that was collapsed in the previous x-ray. There's also what's called a partial knee replacement, which you're able to replace the inside or the outside. And this is metal, and this is plastic. As you can see, there's nothing on this side because in this particular patient, you don't have any serious disease here. There's also the kneecap that also is unaffected. So that's why in this case, we opted to do a unicompartmental, or we call it a uni. Kind of looks like this. It's nice shiny metal, and this is metal, and this is the plastic. So what can one expect with total knee replacement? It is major surgery. You need medical clearance. You have to be healthy enough. This has changed. It is, I don't know if this is, it's inpatient surgery in most cases, which with an overnight stay. This 3 to 5 is not any longer common. We do outpatient total joints now. We do it in a surgery center, and we also do it in the hospital where you come the same day and you leave the same day. You have to meet certain criteria for that. Part of it is that you have to be able to navigate things such as your walker, and you have to pass some sort of prehab such that you know that your post-op stay is foreshortened to that one day. It's not 3 to 5 days anymore. I would say that about 50% of my patients go home the next day. And if it's more than 2 nights, it's rare. The other thing is there's an incidence of blood clots with knee replacements. It's kind of high if without any medication. So we do have to protect you from getting these deep vein thromboses, DVTs. So the blood clots is a serious issue. And the goal is, and it happens, the goal is really to decrease it as much as possible. And definitely the ones that travel, we want to make as close to zero as possible. Antibiotics. That's another thing that you're going to be required to take, because the antibiotics prevent infections before and after surgery. So one of the things that revolutionized, in my opinion, knee replacements is robotic surgery. Let's meet the Mako. It's not a shark, it is a robot. And basically it's a robotic arm and a computer program that uses a CT of the knee that you get up to maybe up to a month before your surgery. And it's not the type of robot that actually does the surgery for you. That's probably coming in some time, but I don't think it's going to be in my lifetime. What happens is you get a CT scan. The CT scan is able to, that's what it looks like, this is the setup. The CT scan is able to make a 3D model of your knee and show us the cartilage, show us the bone, and you're able to before surgery, plan your surgery such that you optimize the optimize the placement and alignment of the knee replacement. So the big thing about why use robotic surgery is not a smaller incision, maybe slightly. There are advantages that go beyond size of the incision. It is a level of precision we haven't seen before. And so what happens is this, it's patient specific, it sizes your knee. The 3D model allows us to perform the surgery before the surgery. Intraoperatively, we do everything else that we would in a traditional total knee, but in this case, we get feedback from the robot telling us when we're doing it accurately, and that's the goal. So it's not like I can sit in the lounge and drink my cup of coffee while the robot operates. I'm doing the surgery, but it really gives you a level of accuracy that we haven't seen before. And when we're talking about realigning your axis, if somebody's bow-legged or is knock-kneed, this is something that we can do with manual instrumentation, but not to this degree. And basically, one of the goals is to preserve as much healthy tissue and bone. Whenever somebody has a knee replacement, there is a chance, or not a chance, there is a shelf life. There is a longevity associated with that. They used to say 15 years would be the lifespan of a knee, and you have to have it redone. It's a little bit more than that. I would say it's on average more like 20 years. But most people, if they have it young enough, will need to have it revised. And when you're revising a knee, you want to make sure that you save all the bone you possibly can. So on day one, when you have your first knee replacement, you want to make sure that you're not taking too much. And that's huge, because you really have the 3D model and your ability to incrementally, even by a millimeter, decrease how much bone you're taking. Perhaps this leads to a more natural feeling knee and a shorter hospitalization stay, and maybe a more rapid recovery. Those have not been proven in a very long-term study yet. However, we are really seeing anecdotal, very positive results anecdotally. So basically, just like any knee replacement, it's usually about a 5 or 6 inch incision. And one of the big things that I like about the Mako is the partial knee replacement is when we do those, they're also very, very accurate. And we've even converted patients who've had partial knee replacements to a total knee replacement to a total knee replacement using the Mako. And so if somebody has had a partial knee replacement, you may be a candidate for a total knee when the time comes. I started using it in 2017, and this is old because we've done much more than 400 total knees performed. I think we're actually looking at something like 300 total knees, maybe 400 total knees a year. And it's, as I said, it's perhaps a quicker recovery, shorter hospitalization stay, but other things that we are advancing in is pain control that does help recovery and aid in the shorter hospitalization stay, including advances with interacting with our therapists earlier and interacting with our anesthesiologists and pain management earlier. We have a program called the Swift Knee, which is an outpatient basis, and it's usually within 24 hours you're discharged, and you basically arrive by 6 a.m. and usually home by 3 p.m. And it's the younger, healthier patients that are candidates, and you are discharged home to begin outpatient PT. All that will be set up prior to surgery, and very important that you are in the prehab mode. So you do your prehab before surgery. You know how to use your walker. You know how to navigate, and the rest is basically traditional surgery, and we go home the same day though. So what can you do after surgery? You can definitely do this. I don't know if I would do this, but usually I advise patients not to start anything that they weren't doing. I let patients ski. I let patients snowboard. I let patients do water sports, work out. There is sort of some activities that I would say would decrease the lifespan, and those are anything that's really high demand. Just like anything, when you have something that's used more, you're going to need. They won't last as long. If you have two cars, one you only drive on weekends, and the other is the go to work car, the one you drive on weekends is going to need their tires changed sooner. So that's not an exact comparison, but it kind of gives you an idea of what we're looking at. There are risks, and these are anesthetic reactions, bleeding, infection, scarring, and this is major surgery. And death is not something that is common, but it is something that can happen. That's why your medical doctor needs to clear you and make sure you're healthy enough. You can have stiffness in the new joint, nerve damage, blood clots, heart attack, or stroke. These are all rare. However, we're dealing with an aging population. And the fact of the matter is, the older you are, there's more chances of having medical problems that really need to be worked out before surgery. Thank you.
Dr. Azer, we have two questions coming up that would be perfect for you to answer. First question is from Anne. Does osteoporosis make a total knee replacement more difficult?
That's a very good question. They can hear me, right? It's a very good question. The fact of the matter is osteoporosis is basically a spectrum. There are cases where it does make it very difficult, that you would have to think outside the box and use other things that are in our armamentarium in order to avoid an early failure due to weak bone. An early failure could be a fracture, even a little microfracture, loosening. These are things that they may not be altogether avoidable, but we do actually have an armamentarium have options that I have to say that that is secondary to our partners in industry that have been trying to work together with us to make that problem not a big problem in knee replacement. But it does happen. It does happen that it makes it more difficult. But it would have to be very, very poor bone for me to really say that it's not a possibility. Does that answer your question? Okay. I have a question and answer thing. Do I type it or?
We do have another question from Gwendolyn. She's asking, she said she's a candidate for a total knee replacement, but she lives in Auburn in Cayuga County. She was wondering if she was able to be a patient of yours.
Absolutely. Yes, absolutely. I don't know how to give my information. Do we have any way to give my information? I can.
Yeah, Gwendolyn, we can certainly, with the email address you've provided to us, we can share his contact information for his office.
There is one thing I have to mention about locations of where to do surgery. It's pretty clear that surgeon experience is very important. For example, if I told you I did 10 of these a year, don't go to me, okay? If I tell you I do 200 a year, then go to me. And then there's other people who would say, if I tell you I do 2,000 a year, then should you go to me or not? I don't know the answer to that one. But similarly, in places that are lower volume, so for example, if a hospital is geared more towards doing total knee replacements and they have a streamlined pathway such that we have a nurse navigator, for example, 2 nurse navigators that take you from step 1 and walk you throughout the way. That helps the patient experience. Number 2, nurses and physical therapists that are there that are used to dealing with knee replacements, not just fractures or ACLs or whatnot, but specifically joint replacements, the experience will be better and maybe smoother. There's also literature that shows that there is sort of a critical number of how many joints done a year is desired. So I'm not sure. I think it's something like 150 joints a year. Then they show that the complications and bad things happening are low if you're over that number. So that's something that I want to add, that there are some hospitals that don't do the volume and are not really geared towards joints. We are very proud of what we've done at Community General. I do operate at Auburn too, by the way, but we've really taken the joint program from the ground up, and we're actually really proud of it. And we have a lot of very positive comments from the patients about their experience there. I have a question and answer, but it says to type. No, answered.
We can field those questions also.
And
trying to keep them all tracked here so we can stay on answering them.
So we have, I'm not getting any audio.
How about there?
Osteoporosis, we saw that too. And then Karen?
Yep.
Do I have to answer or type it?
No, go ahead. I'll save those questions for towards the end there.
Okay.
Okay. I think what we'll do now is kind of shift gears here. Thank you so much, Dr. Azer. We really appreciate it. And we're going to move on to Damon, who's going to talk a lot about the post-operative PT experience. So take it away, Damon.
And I believe we're just, folks, we're just switching over here to the next slide. So just give us about a couple seconds here to get to that point, and then we'll get moving on the last quarter or last third of this.
Apologize, I'm just going to get the presentation up here. screen share here. Okay. All right. How's that? Is that up? Okay, yeah. Apologize, I thought I had this up. How's that?
Alrighty, folks, let's get into the last third of this whole presentation. My name is Damond Archung. I'm a physical therapist here at Onondaga Physical Therapy. I actually practice outside of this location we're at right now in Liverpool, but I'm out in DeWitt. So I'll get cruising here. Mary, are you?
Yep, I'm sorry.
Switch out of that.
I was trying to get myself muted.
So anyways, we'll get moving here. So basically my portion of the presentation is to take you through everything that happens after surgery. Now, the biggest question usually is after surgery, what happens next, right? Dr. Azer talked a little bit about it. I'm going to get a little bit into it as well here, and we'll save all questions at the end. So generally, like how Dr. Azer said, timeline as far as hospital stay can vary drastically depending on location, depending on hospital, depending on the surgeon. Research has shown about 2.5 days with inpatient skilled physical therapy. However, as Dr. Azer kind of outlined before, we're kind of narrowing that down quite a bit to really 24 hours or same day surgery, getting people back into their homes as soon as possible. And whether or not you go back home is determined by a lot of different factors. One of those factors is, well, how safe can you be at home? If you're not safe to be able to live at home, or maybe you don't have enough help at home, depending on the level that you're able to be at that point, then maybe the home isn't going to be the place you get discharged to. Hospitals really are for that very acute patient. So very early on in that rehab, very early on in that right after surgery. So what very well could happen is that you end up being sent to a skilled nursing facility. And everybody knows, I know, no one wants to go to the dreaded nursing facility, the nursing home. No one wants that. It sounds scary. It sounds like you're going to be stuck there. But the goal for that place is really just to kind of bridge your ability to be safe within the home and that surgery. So it's usually not that very long term of a stay. They try to get you as functional as possible, as soon as possible, and get you back in home as soon as possible as can be. So that decision is really made by, as Dr. Azer said, that physical therapy team in the hospital, the nursing staff, the social working staff, and also the nursing staff and the doctor staff as well. So once you are cleared by that staff and say you are either going to the nursing home and cleared from there or go straight to the home in general, there's two kind of options. One of those options are, okay, you have the functional ability to be safe at home, but you may not be ready to get to an outpatient physical therapy. An outpatient really means that, okay, outside of the home. So any location outside of the home, such as, well, Onondaga Physical Therapy, we're an outpatient place. So if you're not able to get to an outpatient place, maybe you're not ready to drive yet, maybe that it's really hard to get out of your home, maybe you live on the top story of an apartment complex without an elevator, whatever it may be, there's going to be a bridge, bridge to bridge that gap of care. So what may happen is you might have in-home physical therapy or some in-home services. So that usually, if that has to happen, that'll happen for about 2 weeks or so, give or take. And then outpatient physical therapy starts. So usually by week 3, 4, you get cruising pretty quickly, getting into the clinic and getting that rehab journey started, getting back to what you want to do and how you want to do it. Very next. So there's a lot that goes into post-op physical therapy, so all the physical therapy after. We're not going to get too much into the weeds of that, but what we'll talk about here a little bit is kind of range of motion and why it's important. And we're going to focus on the knee bending. Early on the extension, so how well you can straighten that knee out, is a little bit more important than the knee bending, but it also comes a lot quicker than the knee bending. And usually the knee bending seems to be the more of the focus towards the later end of PT, as well as the beginning. So it's a good way of kind of demonstrating the importance of certain ranges and how that is functional. So on here, we have just a nice little table, some degrees that you need to achieve some of this range of motion or some of these functional milestones. We're not going to go through it too much, but we're going to focus on such as sitting. You need 93 degrees. So that is a perfectly right angle, a perfect corner angle with your knee and a little bit past that. And it's really important. If you notice some of these ranges, may seem a lot. Usually the goal for a total knee is about 120 degrees. That would get you to all these ranges, but a lot of times we don't quite get there. And this about 50% of people actually only end up about 110 degrees. So that's a really important thing to think about when it comes to ranges. Like, okay, I may not be able to get the full range. Now what? That's where physiotherapy comes into place, where we can really help modify some of your activities, find ways to work around some range deficits and make you as functional as possible. Very next. So this is a nice little graph that kind of shows generally where you end up with the surgery, depending where you start off. Usually after surgery is pretty predictive of how much range of motion that you'll get back towards the end of it. But I want to really focus in on that first 40 days is the most important time frame for that range of motion gain. Now, Garry talked a lot about the prehab, and so did Dr. Azer. And doing the prehab is important, not because that it'll get you more out of that knee necessarily. They've been shown that doing prehab or post-op, or just doing one or the other, or excuse me, just doing the post-op rather, that doesn't necessarily mean that you're going to get better function out of that knee. However, what's important is the acute phase. So that first 40 days, if you did the work beforehand, if you did that pre-op or that prehab rather, and you were able to push through some of that pain and got to hit the ground running early on, you have a much easier time in that early stages of physical therapy. So let me tell you, when I say this, it is not fun that first 40 days, that first month and a week about, if you have not done the physical therapy beforehand. Things are a lot more painful, things hurt a lot more, and it's just not a fun time in PT. Having said that, we will get you where you'll end up going. So the end result will probably be the same. The road to get there is a lot more bumpy. So do yourself a favor, do that prehab, and go on the easier path to recovery rather than that bumpy road. But about 50% of a traditional knee, I'm not sure about the Mako knees, as Dr. Azer talked about, but of a traditional knee replacement, people start off about 85 degrees. So just a little bit below that, going up and down stairs and sitting comfortably. And they'll get to the 110 degrees by that 40-day window. And then things kind of peter off from there. So next slide, please. And me and Garry now are just going to kind of demonstrate why it's important to get that range of motion when it comes to a functional activity. So we're going to show you how it looks when Garry tries to stand up with not enough knee range, just enough knee range, and then a little bit extra knee range, and how much easier it is the more range you have. So we're going to transition over here. Alrighty, so I'm gonna take a knee so I can fit in the camera. And if you didn't recognize me before, I was in this plinth right here, and I had my Zoom attire on, which means business up top and shorts on the bottom. So now I've costume changed a little bit, and we're ready to rock and roll here. So right now we're probably about just extended past 9 degrees. So we're going to put him in an 83 and 85 degree range, which is about what 50% of people are going to end up with directly after surgery for a traditional knee. So Get you up here. And bump up just a little more. Perfect. All right, and as you can tell, Gary's a pretty experienced therapist, so he almost had that perfect when we started off here, so that was awesome. So right now, what we're gonna have Gary do is try to stand up when he doesn't have enough knee flexion. So it doesn't quite have enough range, which we would expect, which is at 93 degrees. So we're about 10 degrees away from that right now. So Gary, when you're ready, I'm gonna have you try to stand up. And as you can see there, his knees started shaking. He really had to thrust forward, and that was not easy now, was it, Gary?
No, it was
He's
not.
shaking his head. We can only see the waist down right now. All right, there. And Gary's a really strong guy. Not everybody can do what he works out. He's pretty fit. He also doesn't have any knee pain. So if you only have 83 degrees, 85 degrees, especially working up right after surgery, you're not gonna be able to do that, and that's not gonna feel too good. So now we're gonna put him in 93 degrees here. And bring the knee back a little more. That's pretty good. All right, so 93 degrees, this is the minimum amount as far as what the research says of being able to get up and down relatively functionally. So Gary, without further ado, stand up and look at that piece of cake.
Awesome job.
No knee shaking. He got popped up and down, didn't have to rock back and forth. Did an excellent job there. And now the last thing we're gonna do is, okay, we're at the minimum. What happens closer to that 110 degree range that we're probably most people are gonna fall? So Gary, if you can pull, yep, perfect. We'll double check here. All right, pull back a little more. Good, and that's about 105 degrees right there. So a little lower than that max range that most people get. So Gary, I'll have you stand up one more time for me. Look at that. That looked easy. Right back down. Now, Gary, out of those three, the first, second, and third, which one was the easiest?
Oh, the third one.
Third one. And folks, if you want to do this at home, if it's safe for you to stand up out of a chair with it relatively ease and you're not in a whole lot of pain, you can try it out yourself. Try it with the knee not fully bent, a little bit out. Try it with it a lot more bent closer to you and see the difference. Feel it for yourself. But only if you're safe at doing it at home and you're in a relatively pain-free state. So we'll switch back over to the presentation and we'll finish up here for the last couple minutes. Thank you, Gary. I was muted. Let's start over there. I was muted. I think we're good to go now. So a lot of what we're going to transition here to is a little bit about the extra exercises, the higher level activities that a lot of people want to know if they're going to be able to get back to, and how likely it is that you're going to get back to that activity or that thing that you love to do. Maybe that knee pain's been holding you back for quite a while. So the earliest people get back to kind of that sporting type activity, that higher level exercise, is going to be 3 months post-op. So that's actually really aggressive with a lot of knees out there. And that's really geared towards that younger patient, that 55-year-old who's coming in real early to get that total knee. Like how Dr. Azer kind of alluded to a little bit, we're doing knees a lot earlier than we used to. Part of that is more towards the side of knees are lasting a little bit longer. The material is lasting a little bit longer, and we've had some advances with it. So 3 months, that is the top 99th percentile person. Most people aren't going to fall in that category. Average time is going to be about 6 months post-op before you can start getting back into that recreational activity that you've been putting off for a little while because the knee's been hurting too much and you've just had a pretty invasive surgery there. So it may take a little bit longer, may take a little bit less, but 6 months, that's the average for the most part. And as Dr. Azer talked about there, if you're not participating in a sport or activity in the past year or so, unlikely you're gonna get back to that activity. That's what the research has shown. So if you've been out of practice, say you want to go get back into that higher level task, say it's like a tennis of some sort, like a doubles tennis. Well, then if you haven't played in 30 years, this knee replacement, it's not a magic surgery as much as we wish it would be. It's really designed to help you get back to the activities you've been doing recently and do it with less pain. It's not going to completely transform your life, but it will help you do some of the activities you've been doing with less pain and get you more mobile. That's an important thing to think about. It's not magic. So, and another thing to consider here is about 75% of people who, after the surgery, they're not going to get to that same exact level of performance that they were at for that sport or that higher level exercise. You'll be able to get back to that sport, but it may not be quite as, you might not be able to perform as well as you once did. And knowing that beforehand, it kind of helps the psychological part of things a little bit too, with the expectations. So take everything with a grain of salt. And next slide. So there's a couple factors that kind of go into returning to that higher level sport, the higher level exercise. The first thing is age. As I talked about just before, the younger you are, the more likely you'll get back to that sport, that physical activity that you want to be able to get back to. 55-year-olds, that age bracket, who are having that younger knee, that younger total knee replacement, they're more likely to get back to that higher level activity. Mainly because, well, you're younger, you bounce back quicker, and it's just easier walk in the park as far as the surgery. And the surgery isn't a walk in the park by any means, but compared to the older group, people recover a little bit quicker and a little bit more functional, which is obviously a good thing. The second thing is motivation. If you don't want to get back to that higher level activity, that higher level exercise, that sport, well, then you're not going to get back to it, and that's okay. You don't have to get back to it. No one's forcing you. You get what you want out of this surgery for the most part. So the more work you put in ahead of time, the more you're going to get out of it. And that goes for the prehab. It goes for the post-op therapy as well. And it's to get to that higher level exercise, the higher level sport, it takes quite a bit of motivation to get there because it's not easy. It's not easy to go from not being able to stand up very well to all of a sudden, okay, we're playing golf, we're swimming at a high level, we're playing tennis again. There's a big gap to kind of close right there. And then sport participation 1 year before surgery. So that's the really big thing. If you haven't been doing this or the activity you want to do in a long time, maybe it's been 20, 30 years before you've picked up a tennis racket here, chances of you being able to do that after the surgery is pretty slim to none. Again, it's not impossible. I'm not going to say anything's impossible, but the cards are stacked against you a little bit. So just keep that in the back of your mind as far as expectations go. And the fourth thing, again, Dr. Azer talked about this a little bit, is weight. So if you're in the overweight, obese bracket, you're less likely to have a favorable outcome when it comes to sport and exercise, but also for all surgeries in general. The more weight we have on us, the more stress we put through our body. Your body has to work a lot harder for it to do just about anything. And that increases our pain, increases our dysfunction overall, as it takes a lot more strength as well to be able to do the things we want to do. So if you are overweight or maybe in the obese spectrum, I know COVID's been rough on all of us. The quarantine hit me hard. The fridge looked real friendly for a long time, and I packed on a couple pounds myself. But the best thing you can do is start getting on that weight loss journey if you are in the overweight category or above. Especially if some time before your surgery. So that might sound like a daunting task there. And the best thing that you can do is consult with a nutritionist, a dietitian, a healthcare specialist who really specializes in weight loss and specializes in nutrition and diet. And not only it would be helpful to get on the path to that lighter weight, but also if you have any other health concerns such as diabetes, high blood pressure, you name it, having someone along the way to navigate through some of these challenges would be a really important thing. Next one. And lastly, these are the, well, recommended, that's in air quotes, exercises after a knee replacement. As Dr. Azer also talked about here, this is not all encompassing, and there's a lot more higher level things that you can get back to. But this is what the typical person that's been kind of theorized at this point will be able to get back to based on just the impact of it. For the most part, there's not a whole lot of research behind the higher level tasks and higher level activities and impact and how that works on the joint. But theoretically, the more impact the activity is, the more risk of hurting the implant there's going to be. So one of the things I just want to key in here with this screen is walking. Now, I know I said if you're not doing an exercise or not doing a sport participation activity a year before you have the surgery, is less likely to be able to get back to that level of activity or do that activity in the future. Walking is one of those things that is kind of outside of that category. So after surgery, you're going to be feeling better if you're in a high level of pain, which is usually the reason why people get this surgery. Starting on a walking program and starting to implement more health and cardiovascular exercises into your daily life is going to make you way more functional, just explode and expand your quality of life in the future and really help your longevity. So if you're not walking right now because maybe the knee is just getting in the way with the pain, doesn't mean you're not going to be able to do that for exercise later on. And it's also a really good thing to start getting into if you can tolerate it right now. Is I'll just set you up not only now, but for the future as well. No one wants to be the person who can't do everything that they want on their own, especially later in life. They don't want to be the person who depend on others. And walking is one of those things that can help really, really improve the quality of life that we have, especially in our later years. And last, I always like to end these presentations with a little bit of a quote here to kind of sum things up all the way. This is from Eleanor Roosevelt. "I am who I am today because of the choices I made yesterday." That really does kind of encompass everything we're kind of talking about here. So if I had to leave you with anything, that's going to be do the pre-op rehab, do the prehab there, do the physiotherapy before the surgery. It's going to make that first 40 days so much more pleasant, so much less painful, so much just easier to get to where you want to go than if you don't do it. I can tell you there's a big difference from those who do the pre-op versus who don't. And they're in a lot more pain, and PT is not fun for anybody here. So do yourself a favor, do that prehab. And if you're looking for a place to go, Onondaga Physical Therapy can really help you out there. So at that, thank you all for hanging in there with us through the technical difficulties and the glitches. You guys were awesome. And we're going to open it up for questions here. I'm going to throw it back to Mary. And I hope you all have a great night. Thank you. Yep, working on that.
Okay, so we are going to open it up now to some questions. I've got the panel of questions up here. Marcy asked a question for Dr. Azer. How much does a meniscus tear contribute to arthritis? Also, how much does a meniscus repair speed up arthritis?
My computer died, so. So to answer the question about the meniscus tears, so you can't really ascribe or assign rather a percentage of pain secondary to meniscus tear or secondary to the arthritis. What I would say is that meniscus tear does contribute to degeneration, meaning it's a injury that destabilizes the knee, and an attempt to repair the meniscus is something that can be done to try to avoid that. But truth be told, the results are variable, and not every meniscus repair actually does prevent arthritis. So the other thing is that removing the tear and not a repair, a debridement, meaning removing the tear, a broken piece, is really for mechanical symptoms. It really doesn't do much for the stability of the knee. And usually people who have meniscus tears do wind up getting arthritis.
Awesome. All right. We have another question, I think, for Dr. Azer as well. When do you know the time is right for a knee replacement?
Okay, very good question. Everybody's different. I have a patient who is in his early 80s, I think now, who comes to the office once a year. He has bad arthritis, and he happens to ski every day on Greek Peak. When you take a look at his knees, he has horrible looking knees. And I don't know how he does it, but he's out there every day in the winter. He has got a ski pass and he skis. That's what he loves doing. So he comes into the office and asks me, what should he do? Well, if he has the ability to ski with minimal pain, and that's what he's reporting, then there's no reason to do a knee replacement. The time for a knee replacement varies from person to person. There's a point where you've exhausted all the conservative measures such as medication, physical therapy, injections, bracing, and then you've done everything. And at that point, it really is time to consider it. Now, that has to be guided. I mean, you come into my office or you go to an orthopedist's office and they guide you and tell you, listen, these are the options you have left. And the quite honestly, that point where you're ready is a personal thing. Not everybody is ready at the same time.
Awesome. I have a question from Mary Lou. Do you use Mako system for hip replacement? How does that affect rehabilitation time?
Yes, I do the Mako for hips. I don't think it really affects rehab time. I think anecdotally or as an observation, I think our patients that have the Mako, the hip done with the Mako may have a slightly shorter hospital stay, but I can't say that that's the end all be all, that every single person that has a Mako hip gets out of the hospital faster or recovers faster. I would say they're pretty much the same. I think that the point of the Mako is really longer term and not short term. It's not really for shortening your recovery by much, but I think it's more looking into the future. How long will the joint last? What will your outcome? What would the outcome be? Meaning, what are the results? How is your pain scores? How is your function scores at a later time after convalescence, after you've recovered? But initially, I don't think it's a huge difference.
Okay, thank you.
Yep.
We did have another question I'm going to field over to Damond. Karen had asked, she fell and sprained the left side of her right knee. Is there anything else she can do? So I'll take that over to you, Damond.
Alrighty, Karen, that is an excellent question. And I'm sure it's a scary question too, because you probably have some pain going on with that. The best thing I would say is every sprain, every fall is different for every person. It's hard to say exactly the best thing to do without taking a look at you first and be able to individualize exactly what your treatment plan needs to be. So my best advice would be come in, get some PT, get an eval done. We can tailor everything that you need, get everything down to the T, anything that you need to get you back to where you want to be. That would be the best way to do it. So I would say schedule an appointment for physiotherapy, get evaluated, and we'll go from there and get you on the path to recovery here. But excellent question.
All righty. Thank you all so much for all your questions. We don't have any open questions in the queue right now, but we'll kind of leave it open for a few more minutes if people come up with a couple more questions for us. Just as a reminder, you will, when you sign off, be getting a survey to fill out. I know we had some technical difficulties, and like Damond said, we really appreciate you guys staying on board with us through some of that. We're working out some of our kinks for our next one, but we really do appreciate the feedback on the information and the knowledge of the presenters as well. And honestly, if you have some suggestions for other webinar topics, tomorrow you will be receiving a recorded copy of this. So if there's any information that you feel like you may have missed, you'll be able to review it as many times as you like. Um,
Like my
Office number.
Office number and contact.
We can certainly add on, so you'll have some contact information for Dr. Azer as well. Good question. That's right. Okay. Yes, Damon said, cue the elevator music. Well, I think I'll give it another minute, but if we have no further questions, we'll just be signing off for this evening. And thank you guys all again for attending, and we hope to see you again at our next webinar, and maybe even a live and in person when the time is right.
Fingers crossed.
Fingers crossed. All right, well, thank you all so very much. Have a great night, and thanks again.